I really will provide an overview of what is known about common symptoms that are present in folks going through pancreatic cancer treatment, and share a bit with you about how a palliative care clinician such as myself thinks about these problems. Also, hopefully provide some cues or coaching to those of you who are family members of patients or patients. I think we make an assumption on the treatment side of this, which is that it's self-evident what we want you to tell us, but all the evidence and certainly my informal interactions with patients and myself when I'm a patient realize that it's not at all clear. So hopefully I will shed some light on that. And then talk some about evidence-based treatments, since, as you know, the world is full of many opinions about these things, and I thought you'd be interested in seeing what the science says. So this catalog of miseries is a list of common symptoms, and I've highlighted in this sort of weird, creepy blue the ones that, at least in populations who've been studied, are most common in patients with pancreatic cancer. And those include, of course, pain, nausea, fatigue, appetite problems and weight loss, low mood, and then in the other column, steatorrhea, fancy word for the diarrhea associated with difficulty absorbing nutrients due to blockage or lack of production of pancreatic enzymes, and other kinds of gastrointestinal symptomatology, which we may not really have ideal words to describe. And then finally, jaundice and itching, PERT, a medical term for itching, again, most commonly when patients have obstructed biliary drainage. The other items on this list are, there's no law against having those, but they are less common, again, in populations of pancreatic patients who have been studied. Again, this may seem like a slightly moronic question. Well, everybody knows what a symptom is. Yes, but by putting up the definition, I mean to emphasize that it has to do with the subjective experience of the sufferer. Therefore, it's not something that anybody can observe. It's not something that anybody but the sufferer can measure or describe. And again, we need that. And even if it's, pun intended, painfully obvious to the person telling us about it, that is not sufficient for us to really get it. So we've, of course, developed rating scales and a bunch of other ways of measuring, but we still don't have a blood test or a brain scan for pain, as one example. And the effort to articulate the nature of the symptom is probably worth it if the goal is to get the clinician to understand as fully as possible. What causes symptoms during cancer treatment? Well, often more than one thing. Certainly the disease itself can be an important source of symptoms. Our treatments often add or amplify or exacerbate, at least initially. Of course, pre-existing medical problems that have nothing to do with the malignancy can be a cause. A new onset medical illness that is unrelated to the cancer, but simply simultaneous, and there can be other causes as well. And again, it's incumbent on we, the treaters, to figure that out in partnership with you. The term symptom burden, which has emerged in the last 10 years or so, is intended to speak to sort of the sum total or severity of the impact of symptoms on the person suffering them, and something that we think about as we try to measure bringing benefit to patient. That's partly about looking for patterns. One of the things that, if you read the literature these days, you see reference to the concept of symptom clusters. Clusters meaning groups of symptoms that tend to present together in particular disease states. And again, that may seem like an unimportant distinction, but it really does help us design treatments. It helps us have a better set of hypotheses coming in as to what someone is likely to experience, and we think it's valuable. So one of the take-homes that I hope you leave with, we really do need you to report, because that's the only way we can know what you're experiencing. I frequently, when I explore this with my patients, know or learn that people are disinclined to describe the full litany of what they might be experiencing because they kind of have this magical thinking fear, well, if I have too many symptoms, that must mean something really bad about what's going on, or it will alienate or bore my clinician, or lead to some other unwanted outcome. So I'm going to sort of tone it down. I think until you get a cue from your treaters otherwise, I think it's best to err in the direction of over-reporting rather than under-reporting. So I would suggest, again, that's one of the take-homes for you. Again, if you read the literature or surf the web, you probably are quite acquainted with the concept of evidence-based treatment guidelines. This is something really that we began in this country to do in the early 1990s so that we would trend towards offering the same optimal therapy in Los Angeles for a disorder disease that you would get in New York at the same era in human history. There still are regional differences, but as we move towards accountable systems, which actually are required to provide evidence for why they're doing what they're doing, not just opinion or because the last time I did this it worked, but evidence, these kinds of treatment guidelines are extremely important. How are they arrived at? Basically, you invite a bunch of experts to the National Institute of Health and you lock them in a motel in Bethesda for a weekend with photocopies of all of the studies in a given field and make them read all the articles even though they've read them all before and rank them on quality and quantity. And of course, that's a slightly abbreviated version of what happens, but from that really emerges a ranking of the quality and the magnitude, and that really helps us make better judgments. So when it comes to symptom management, here are 4 organizations that really provide excellent web resources. The National Comprehensive Cancer Network, which has a beautiful set of guidelines for supportive care or palliative care in oncology, the American Cancer Society, the NCI itself, and the Cochrane Collaborative, which is based in England and which likewise does very excellent work. I think relying on entities like that for information about treatment is a wise strategy because, as you know, there's, the web is essentially unregulated. And I think for people facing a critical, potentially life-threatening illness who are information seekers, who are educated, who are used to using knowledge to improve their lives, and I've seen this over and over again. I haven't named the disorder, but it has something to do with obsessive use of the internet all night long in preparation for the consult with the oncologist disorder. And it's totally understandable, and I have done it myself, and I would do it. But the problem, again, is that it's really hard to separate the wheat from the chaff in that setting. And so it's simply important for a buyer to beware. And here it is, danger due to misinformation. So take home point 2. And here's a cartoon. I already got a diagnosis from homedoc.com, but I thought I'd see you for a second opinion. So. Okay, so enough of the preamble. I now want to talk a bit about specific symptoms and their management, and I'll start with pain. Certainly a symptom that is common and that casts fear into many people's hearts unnecessarily, in my view, because we have really terrific pain treatments. I think optimal pain management during cancer treatment is not just a scattershot of throwing more opioids at a pain problem. It really involves thinking about what is the pathophysiology, what is driving the pain. So we have visceral pain, which is highly responsive to opioids. Visceral pain is pain associated with internal organ, solid organ, like a pancreas, or a hollow viscus, like bowel. We have bone pain, which is not necessarily so opioid responsive. You know, you've had a fracture or some kind of injury like that. Although opioids can work some for bone pain, they're often not optimal alone. We have neuropathic pain, pain associated with injury, technically injury to the nervous system. Specifically in cancer, that's usually pain associated with either injury that chemotherapy may do to peripheral nerves, so burning, tingling, numbness, or sometimes pain associated with a tumor compressing a neural structure. And again, different treatments for different kinds of pain. Working with somebody who thinks that way is going to help you a lot. Of course, anti-tumor therapies, when they work, when they shrink a tumor, when the chemotherapy shrinks the tumor, when the radiation obliterates the metastatic disease to bone, are very potent pain relievers and often are by themselves adequate to manage pain. Pancreas cancer is one of those cancers where a specific interventional procedure called celiac plexus block has historically been seen as the gold standard or go-to treatment. I'm going to show you a little bit of data, including some data actually about the use of endoscopic ultrasound, to pick up on Dr. Wilcox's previous talk, as an alternative to sort of standard celiac plexus blockade. A wide array of pain medications, which when used skillfully are effective, safe, and a huge element in improving quality of life. Some non-medication behavioral approaches, which are very potent. Some physical therapy and postural approaches, and actually there's a small acupuncture database which you may be interested in learning a bit about. This was actually, I think, the most rigorous trial ever done of celiac plexus blockade. It was done at the Mayo Clinic, and it was a true randomized, double-blind, sort of placebo-controlled sham trial. So people either got a real celiac plexus block, or they got an oral pain medication, or they got a needle stick and in the general area where a celiac plexus block is done, but they didn't actually get the celiac plexus block and oral pain medication. The celiac plexus, I reminded myself before coming up I should define that. The celiac plexus is a bundle of nerve tissue that sits in the back of the abdomen, behind the pancreas, behind the stomach, just in front of the spine. And it's sort of the relay point for the sensory input from the part of the gut that the pancreas is into the central nervous system. Celiac plexus block either numbs up or obliterates that plexus and can have an important role in reducing pain associated with a number of internal organs, including the pancreas. And that can be completed, or that process can be done by a surgeon during an open abdominal procedure, by an anesthesiologist or an interventional radiologist using CT or other guidance with a large needle that is sometimes approached through the abdomen and sometimes approached through the back, and as you'll see can also be now performed using endoscopic ultrasound. So from the Mayo Trial, I'm sorry this doesn't project particularly well, the finding, which I will tell you in words, was that oral medications alone and sham celiac plexus block versus real celiac plexus block and oral medicines. The real celiac plexus block folks got a little bit better pain relief at the beginning. Over time, though, their pain control was, again, just a little bit better, had no impact on survival, no impact on their self-reported quality of life, and interestingly did not reduce their requirements for oral pain medications. And although I have sent many patients for celiac plexus block, it does not seem to be the magic bullet. It does not make the need for systemic medications disappear or go away. And so really often it's a decision that is made, if it's considered early on. It's a little bit about the disposition of the patient, who some people are, big intervention, let's do it, and some people are, I'd rather not have another procedure, thanks very much, I've been messed with enough. I don't think there's a right answer, and so I think the important thing is to have one or many discussions about this particular procedure and to follow the patient's lead in that regard. Again, I mentioned the endoscopic ultrasound. This is just published last year in the Journal of Clinical Oncology, about 100 patients who were randomized to endoscopic ultrasound or routine pain management with, again, oral or transdermal medicines. Very much same result as the one I just showed you from the Mayo, which is a little bit of reduced pain up front as a result of the endoscopic ultrasound. No ultimate impact on how much pain medicine patients needed over time, or quality of life, or survival. So I think, on the other hand, this is I think it would be fair to say, a easier and likely safer procedure. I don't know if enough of these things have been done yet that there's much in the way of morbidity statistics available. Do you know, Dr. Wilcox?
Most of the studies, it looks like it's relatively safe.
Yes. Okay. Okay, so that's sort of a very quick and dirty discussion of pain. In the interest of covering some of the other topics, I will move on and talk a bit about nausea, which is something we've made very significant advances on in clinical oncology in the last 20 years, as you probably know. The revolution really came with the arrival of, the first one was Zofran or ondansetron to the market. These are drugs that block a particular kind of serotonin receptor called the 5-HT3 receptor, and they are very potent and very effective, at least for chemotherapy-related nausea. They can sometimes be less effective for nausea associated with other problems like partial or complete bowel obstruction, and that can be more challenging. There's another class called the neurokinin inhibitors. These are the names of the drugs, the generic names. There are drugs which, for lack of a better term, act on the vanilloid receptor. They are nabilone and dronabinol. The vanilloid receptor is a fancy term for one of the receptors in the human nervous system that cannabinoids, that is molecules derived from marijuana, seem to act on. There are the conventional cannabinoids, the kind you can buy at the local dispensary. There is the benzodiazepine class, in particular lorazepam, which is Ativan, which is part of almost all pre-chemotherapy cocktails. And then there are the class known as phenothiazines, which are drugs like compazine. They all work, as does metoclopramide, as do corticosteroids, drugs like Decadron and prednisone. And actually, acupuncture, if you look at those Cochrane reviews, which I mentioned, there are two symptom areas where the evidence is pretty strong in favor of acupuncture. One is certain kinds of pain, and the other is nausea. Almost all the other stuff for which acupuncture is used, there is less robust data. And as somebody who does acupuncture, I'm not being snooty or snarky. I'm just saying that I feel very confident doing acupuncture for pain or for nausea. I feel less confident in other areas, which doesn't mean that it shouldn't be pursued or considered. Fatigue is a very complex problem. I think it's fair to say that we don't have much of an understanding of what drives it. It's highly prevalent in many chronic illnesses, including malignancies. Pancreatic cancer is no exception. We do lots of stuff, and our interventions are not very effective. That includes managing hemoglobin. Hemoglobin, of course, is part of that hemoglobin hematocrit. Studies that measure how much red cell volume you have in your body, because we figure if your blood count is low, your blood's oxygen carrying capacity is diminished, and since you need to send that oxygen to your muscles and other important places like your brain to feel fully awake and alert and to be able to move around without exhaustion, making sure you have enough red cells around is important. And indeed that seems reasonable, but replacing hemoglobin, normalizing hemoglobin, actually turns out not to have a particularly potent effect on fatigue. Teaching folks to pace, teaching folks to think of their energy reserves as a finite, unfortunately, a finite resource, particularly for type A folks like myself, is a very challenging thing to do. But indeed, if you save it up so that you'll have the energy to go out to dinner with your family later, or you'll have the energy to go to the book group, because you know you only have 5 or 6 hours of really feeling like yourself in a given day, sometimes that's the only reasonable solution in the short term. Sleep hygiene is important. There is actually a pretty strong evidence base for the use of stimulant medicines for fatigue and lethargy in chronic medical illness. The strongest evidence, the most studies have been done on the drug methylphenidate or Ritalin. There is a newer class of wakefulness promoting agents which you may have heard about. The original one was Provigil. There's a new one which is Nuvigil. They also have been studied in patients with cancer, and they also work, although some of the more recent studies suggest that they take a few weeks to kick in, whereas the conventional stimulants work right away. and there's a nice flexibility, which is you don't need to take them all the time. You can take them only if you feel the need for them. So again, if you have a social event that you want to be feel energized for, you take them that day, but you don't take them other days. And we can talk more about that in the Q&A period if you like. The acupuncture data is pretty weak in my experience. Treating fatigue with acupuncture is not very inspiring. If fatigue is a complex symptom, anorexia weight loss is even more so. We think that the physiology of anorexia and weight loss in cancer has something to do with these things we call pro-inflammatory cytokines, which are proteins that are produced by the host person's immune system in response to tumor antigen and perhaps some of the other biologic elements of the disease, and which drive changes in cellular function that lead to wasting. And that's why repletion with calories, as hard as an idea is to accept, often doesn't have an impact. So this, of course, is one of the most disturbing and upsetting things for patients and families to observe, particularly with the amount of symbolic meaning for all of us in eating and in food, and a huge topic in and of itself. The strongest evidence in favor of medication to counter or slow wasting is for megase, megestrol, which is a synthesized version of the hormone of pregnancy, progestin. Corticosteroids may also have a role in this. And then there, of course, are medicines that are used not so much to try to change cellular metabolism, but rather to stimulate appetite. And those include dronabinol, again, which is the marijuana derivative in a pill, cyproheptadine, which is an antihistamine, pentoxifylline, which is a drug used actually for other purposes, hydralazine, and fish oil. And these have been discredited in good studies, specifically discredited in terms of lack of an effect on helping maintain body weight. There's some on-the-horizon therapies that you might be interested in knowing a bit about, and they include this hunger hormone called ghrelin, some other neuropeptides, and in light of what I said to you about the pro-inflammatory cytokines, drugs that are inhibitors of TNF, tumor necrosis factor, are drugs that seem to antagonize or block some of the physiologic effect of those pro-inflammatory cytokines. There's some evidence that oxandrolone, which of course is what the guys in the gym who want to look beefy inject, may have a role in this setting in a medically appropriate supervised use in helping maintain lean muscle and body weight. Thalidomide, as many of you know, is back. It's actually a primary therapy for multiple myeloma, but also has an important role or potentially important role in weight loss. And melatonin may also have a valuable role here. So breathing difficulties, another complex symptom, and the subjective experience of breathlessness or of labored breathing, again, can be caused by a long list of metabolic drivers. There's not a single medication treatments for breathlessness, and so I don't try to outline it here. This really requires a medical evaluation to sort of try to address it. Sweats and hot flashes are another area that have gotten a lot of attention, particularly in women with breast cancer, but certainly in other malignancies as well. Much promotion of dietary additives and vitamins and health food remedies. The studies actually confirm that what we call SSRI antidepressants, drugs like Prozac and Paxil, and although it's not an SSRI, Effexor, there are actually good studies showing all of them work for hot flashes. And then the other medicine that has been studied and shows efficacy is gabapentin or Neurontin. There have been a number of trials of dietary soy, which has some estrogen-like properties, of flaxseed and of black cohosh, and they have all been negative. They have all shown no effect beyond the effect of placebo, which interestingly has had almost no impact on how much of them get sold for this purpose in this country. And you know, again, that what the studies show, what groups experience is not necessarily what you or I would experience. So I think the important issue with diarrhea in pancreatic disease, of course, is that some folks, either because of the impact of disease on pancreatic function or because of the presence of disease blocking ducts, develop steatorrhea, and supplementation of oral pancreatic enzymes can be an important treatment for diarrhea in that setting. I think I'm actually going to make it in my time allotment to 3:40. Wanted to show you just a little bit, a few snapshots of the NCCN supportive oncology guidelines. So this is brand new, as you can see. It's the 2012 version. They have a website with a whole patient portal. This talks a little bit about surgical palliation of particular problems, but also, as you can see, talks about pain, talks about depression, and some other important areas. A bit about dry mouth. Again, significant problem, particularly in head and neck radiation. Taste changes is more prevalent, and I think experienced by many folks who have had systemic chemotherapy, including folks with pancreatic malignancies. We don't have a single magic bullet. Again, there's actually an interesting small acupuncture literature in this area. Sleep, of course, is a problem throughout our society, so some people come to their pancreatic cancer experience with a pre-existing sleep problem. Others experience it as a new onset problem. There's a lot of common sense that prevails here, including minimizing drugs that may keep you awake late in the day or at bedtime. Sleep hygiene, which really is just the set of behavioral practices that are most likely to be associated with associating the bed and the bedroom with sleeping. Not the place to watch TV, not the place to read the newspaper, not the place to talk on the phone or pay bills. For starters, of course, it's a slightly longer and more complex list, but sleep hygiene can be very potent. CBT, or cognitive behavioral therapy for insomnia, is a very effective treatment, and there are now websites where you can essentially buy a course of CBT for insomnia over the web for $45 and do a correspondence course with the sponsor of the website. And a number of my mood disorder patients have done this and have had really positive results. So, and of course, then there's standard sleep medicines, which can be used and are used. So one of the very interesting things about pancreatic cancer is that it is much more frequently than other malignancies associated with depression. In fact, if you look at the classic textbooks about pancreatic cancer, many of them describe that the classic presentation of pancreatic cancer is painless jaundice preceded by a major depressive episode. That is a clinical depression, often in patients who've never had it before. And this led people to speculate perhaps these pancreatic tumors release some kind of ill humors into the bloodstream, which are depressogenic. They're the kind of ill humors that cause people to develop depression. And maybe that's correct, although we may not have the hardware to discover those ill humors because nobody has been able to identify that. But it is a common comorbidity. Happily, it appears that the treatments for ordinary depression in the non-pancreas cancer setting seem to work as well in folks with pancreatic malignancies as in the general population. We do that when it's indicated and when people are willing to allow us to do that. Perhaps the ill humors will be discovered, but we're not there yet. Another difficult area, thinking in memory problems. We know that they're widely prevalent in people with many chronic medical illnesses. It's not clear that people with malignancies have more or worse thinking or memory problems. In fact, most of the evidence suggests that they don't. Sometimes this can simply be associated with the burdens and stresses and depletion of going through complex medical treatment over a long period of time. There's no evidence that people are at higher risk for developing new onset serious dementia type symptoms associated with cancer or during cancer treatment. So in closing, I I hope that my comments have suggested what I will now say directly, which is that I think for all elements of treatment, it's really important to seek a collaborative working relationship with your treaters, and I think that's important across the board as you consider primary treatment for a malignancy, but also as you communicate about personal health values, as you think about pain and symptom management. The rule in this country, it's no longer the exception, the rule, that is more than 50% of people receiving standard conventional anti-cancer treatment at places like the Norris or our cancer center here at UCLA are simultaneously doing something that would meet the criteria for CAM, complementary and alternative medicine. It's so, it's no longer counterculture, it's almost standard. And so the important thing is that you communicate openly and factually about what you're doing, because we know that some of the CAM stuff can in fact work at odds in a physiologic way, work at odds with standard treatments, and that probably is not a worthwhile thing for patients to be doing. Much of it is not at odds with in a biologic sense, but it's important that your oncologists know what you're doing so that you and that person can figure this out together. I think, in general, working the guidelines, the evidence-based guidelines, before stepping out into the ether and doing stuff that is unproven, to me makes sense. But again, that has a little bit to do with one's own health values and beliefs, right? I meet plenty of people. The last thing they want to do is take another medicine that's a product of the evil pharmaceutical industrial complex, and they'd much rather go to the health food store just because it appeals to them, right? And that sometimes doesn't make a lot of sense from the standpoint of science or rationality, but it's just sort of who they are and what they want to do. And I think as long as it's not, again, destructive, I think we need to support people in doing that. I have used up my time. I was going to say a word or two about palliative care, simply to point out that in 2012, palliative care optimally is available to anyone at any time facing major illness with no assumption about what the trajectory of that illness is going to be. The program that I ran at Cedars for many years before coming back to UCLA was present in the cancer center, and we took care of people many of whom were going to have a cure. We took care of some people who were very late in disease stage and who were actively dying, and that shouldn't be a criterion for whether someone has access to optimal pain and symptom management and supportive oncology services. Just going to end with a mention very quickly of a study that many people, perhaps you have heard of. This is a study done by Jennifer Temel and her colleagues at Massachusetts General Hospital, published 2 years ago. This is a study in lung cancer. Very simple study. Basically 2 groups of patients. Patients with lung cancer who got care as usual, and patients with lung cancer who got care as usual, meaning standard chemotherapy, and were seen by the palliative care consultants at the time of diagnosis and then as needed during the course of treatment. There were some very interesting findings. So again, they got identical chemotherapy. The group that also had the palliative care intervention had improved quality of life, had fewer depressive symptoms, less pain, but very fascinatingly lived about 25% longer also. And the only difference was that they were getting probably better pain and symptom management. I think that is an enticing observation, has not been replicated in pancreatic cancer. But I think it's a strong suggestion that the services of palliative care folks are not just for end of life. And certainly that's how I define what I do. We have inpatient consult services at the 2 UCLA hospitals. We have a nascent outpatient clinic which hasn't opened yet, but we hope will in the next 6 months. And I really thank you very much for your attention.